Welcome to the Proactive Security Podcast with Mike Hodges and Brian Hamilton. This podcast is dedicated to discussing violence prevention in healthcare. We want to inform, equip, and empower healthcare security leaders to prevent violence before it happens. And now, here's your hosts, Mike and Brian.
Hey everybody, I'm Mike.
And I'm Brian.
And this is episode 14 of the Proactive Security Podcast. We are super excited today. We've got David Corbin with us to talk about workplace violence and his concept around a safety from violence officer. Welcome aboard, David.
Thank you. Thanks for having me, guys. Appreciate it.
Yeah, can you just tell our listeners a little bit about yourself, about your background?
Sure. So I have been in the security industry for over 2 decades. Most of that time has been spent in healthcare security. Most recently, I was at Brigham and Women's Hospital as the director of police security and parking. And now I am in the research field doing as a security director, overseeing a large research institute in Cambridge, Massachusetts.
Well, very cool. Well, like I said, it's great to have you. The reason we connected was you put out an article on LinkedIn not too long ago, asking the question or answering the question why you need a safety from violence officer in your hospital. So why don't you tell us a little bit about this idea of a safety from violence officer?
Sure. And, I just wanted to note, although I'm not in the healthcare security field anymore, I do consult on healthcare security. But, I still also have a deep passion for healthcare security. It's where most of my career was formed. So, having an opportunity to step out of the healthcare security director role gave me an opportunity and has given me an opportunity to look at different ways to solve the workplace violence problem. Also, I have clients that are asking me for ways to solve their workplace violence problem. So in that sort of frame of mind, I thought about, hey, why, we have safety officers, we have patient safety officers, we have, my last hospital, we had a laser safety nurse, people who are focused on different aspects of safety in the hospital, which is very, very important. But when it comes to violence, we're, in many cases, tasking the security director with solving that issue. And not in a vacuum. A lot of hospitals now have workplace violence committees or safety committees with a focus on workplace violence. But there's not like one person who's just focused all the time on violence, right? The security director has a lot of other things on their plate, right? And if you manage parking, you know exactly what I'm talking about. Because parking,
we don't talk about parking. We don't talk about parking. Nobody.
We could do a whole separate. You could do a whole separate podcast on parking nightmares in healthcare security. But sort of what I'm getting at is, why not designate someone in the hospital to serve as a safety from violence officer, somebody who can focus their efforts on the prevention and mitigation program, and not by themselves, right? This is a collaborative idea, right? The security director would not be absolved of protecting people from violence, and neither would anybody else. But this person could spend nearly all their time or all their time focused on violence prevention. And this is not meant to be a hero position where they come in and they're the ones that are charged with fixing everything. But to have somebody solely focused on the issue, which is a huge issue in every hospital, honestly, it doesn't matter where you are, would be huge. And I advocate in my article for this person to be a clinician, somebody who's got a clinical background. And the reason for that is that a lot of the causes of violence come back to clinical issues, right? The diagnosis of the person, they may have behavioral health issues, they may have medical issues, they may be, intoxicated. There's a variety of different clinical conditions that you're dealing with that are the root cause of the violence. And then you add on, hey, I know you came in here for this, but now you can't leave. Or I know you came in here because you want to be seen, but now you have to leave. Or we can't give you that medication we want you to have. No, you can't have visitors, right? So you layer things on top of those clinical situations and that can lead to people acting out, right? People waiting too long, they get frustrated, aggravated. So there's a variety of different reasons for why people act out. But if you look at some of the research studies out there, it's clinical in nature. That's where a lot of this comes from. And being able to have somebody on who's got that clinical mindset, who can educate other clinicians on the root causes and look at it from that perspective, I think would be very valuable for any violence program. And when it comes down to it, you really need somebody that can do a deep dive into what is causing violence, right? Because we collect statistics on violence, right? How many people were assaulted, how many verbal assaults, how many restraints we did, things like that. But unless somebody gets really hurt, you're probably not doing a root cause analysis. You're probably not digging deep into each incident. So to have somebody that can dig in, maybe not to each and every incident, but the more high profile incidents, and say, how did this happen? What was the caregiver doing at the time that they were assaulted? There was a research study that was done by some folks over at Brigham Women's Hospital in regards to acts of violence in the workplace there. And they found that I think it was like 90% of all the assaults occurred at the bedside when the caregiver was given care, 90%. So, looking at what was the caregiver doing at the time that was happening? And I'm not saying you're blaming the caregiver, but what were they doing? Are there common factors here? Where were they standing? What were they doing? Maybe it's every time, 50% of those situations where they were trying to, take their vitals or something like that, right? So focusing in on what are the issues that are contributing to the violence, and thinking about how you can take that information and build it into your prevention and mitigation efforts, I think would be hugely valuable. And I know not everybody has the resources for this type of position, right? A large academic hospital might be able to fund something like this. But in a small community hospital, people are going to be like, I can't hire a person just to do this. But maybe that person's a half-time, right? You make it half their job. You clear some of their responsibilities out, you make that half their job. And maybe there isn't enough violence for them to focus on that full-time. But the idea here is to think outside of the box in terms of how we've looked at violence prevention before, and think about how we can leverage the clinical side of things to focus on the problem and work collaboratively with security on this issue.
No, I think that makes a lot of sense. I think, Brian and I have talked about in the past, there is a significant correlation between clinical care and violence prevention in the healthcare environment. And one of the things that I see is a potential opportunity for a position like this is to, while not only, mitigating the clinical indicators or the clinical contributors to violence and creating a safer environment for staff, they have the potential, especially if they're a clinician, which is your recommendation here,
right,
they have the potential to help focus on more positive patient outcomes.
Right.
And I think, sometimes I think we get lost in the workplace violence prevention conversation, especially in healthcare, is we tend to see in silos safer staff, but more negative outcomes for the patient. We see the positive outcomes for patients and positive safety for staff as mutually exclusive for some reason. And I've never understood why that is, because they're not mutually exclusive goals, they're mutually supportive goals.
Great.
And so you can, while keeping the staff safer through clinical measures, and things like violence risk assessments at the bedside, behavioral rapid response teams, adjustments to medications, adjustments to the patient care plan. These things can prevent violence and keep the staff safer, especially when supported by a specially trained healthcare security force.
Absolutely.
But also we improve patient outcomes.
Yes.
We treat the patient more effectively. The patient goes home sooner. We see, reductions in the length of stay. We see reduction in negative patient outcomes like restraints and seclusion. We see reductions in these outcomes across the board in conjunction with having a safer staff.
Agree.
So I think there's opportunity here.
Absolutely. And even if this article gets people to think about a different approach than what they're using today. And this isn't meant to be a prescriptive thing. I don't want you to take take this article and write a job description off of it and hire somebody and expect, miraculous results, but it's meant to kind of change the focus. And, I think about the articles that you see where a healthcare worker has been assaulted and it makes the news, right? And they inevitably ask the hospital to give a comment. And I swear that there's like some repository where you can like pick a comment, and they always say like, we take security and safety very seriously, and we have security. It's like, I know that's for the media, but some of these places will also say, we're going to add cameras. It's like, cameras don't prevent violence. They record violence, and it's a great way to, prosecute somebody later or to see what went wrong. But if you're a healthcare security professional, you can probably count how many times you've watched violence unfold on a camera, right? Patients aren't saying, oh, I didn't hit that nurse, there was a camera in the hallway. Like, no, but you hear the hospitals will say, we're adding cameras, we're going to add more security patrols, right? Those things don't prevent violence. They sound great, right? But they don't prevent violence necessarily. So it has to be at the programmatic level. And I think, the new Joint Commission standards that are coming out that go into effect January 1st, I think are going to help hospitals rethink their programs, right? They're not overly prescriptive, right? But they do include more training and more of a focus on the prevention end of violence. But I think, just from clients that have reached out to me for help, people are thinking about this seriously, and they're asking me, and they're looking internally to say, first of all, how do we get compliance with the new standards? But also, this is a great opportunity for us to look at our violence prevention and mitigation program as a whole. Because I'll be the first to tell them, you don't want to just achieve compliance. You want a program that works for your hospital. You want a program that works for your culture within your hospital. So, but I think those Joint Commission standards are getting people to rethink like what they're doing. Is it enough for compliance, but also is it enough for your hospital? And COVID has complicated everything even more, creating more conflict at the door over masks and things like that. I think I just read an article yesterday about somebody, got their hand broken or a thumb broken or something like that by somebody who didn't want to wear a mask, and people getting punched for not wearing a mask. I mean, in health, it's happening everywhere, but it's happening in healthcare too. So, the problem of violence is getting worse across healthcare, exacerbated by COVID, exacerbated by, long wait times and things like that, overcrowded hospitals in some areas. So I think this is the perfect opportunity to rethink things. But I think that, is it going to be an easy sell for anybody? No. Is it going to be an easy sell for a security director? No. But even if this article gets you to rethink how you're approaching violence prevention in your hospital, that's what I was hoping people would get out of this. But yeah, I think in an ideal world, every hospital would have a safety from violence officer who's focused completely on workplace violence, not just preventing it, but researching it, doing deep dives into into incidents, right? What causes, what was happening at the time, like really digging into them and really doing root cause analysis on all of these incidents would be huge.
Yeah, absolutely. So I think the thing that kind of stuck out for me there was when you mentioned how a lot of times we'll just have hospitals just throw resources at these situations when they do happen. We're going to add cameras. We're going to add patrols. Those things could be helpful, but without that deeper dive, like you mentioned, having someone who's actually going to look at that data, who's actually going to kind of figure out what some of the factors are that are triggering these events, then we can use those other pieces of technology or that rounding that's been mentioned. Then that has a better chance of preventing some of the violence that does occur. Absolutely.
It's unfortunately some hospitals wait until something really bad happens to make changes. And, I always appreciate being brought in as a consultant before something bad happens, or sometimes it's a near miss and it makes them think, hey, let's look at this again. But unfortunately, some hospitals wait. And doing that research, and again, and I'll send you the link so maybe you can post it if you want, about that Brigham Women's study. But they did a deep dive. They looked at what are the causes, what are the things that we can do to help prevent violence, and they came up with a program called the SAFE program that they implemented it. And actually, I don't want to misquote it, but I think it resulted in something like a 40% reduction in injuries from violence among the nursing staff on the inpatient unit. So, but they didn't just come up with a program and put it out there. They did a deep dive. They looked at what are the causes of violence. How is this happening? What can we do to improve it? And they based the program on a research project, and that way they were also able to measure the outcomes at the end. I mean, how many times have you put into place a new workplace violence policy and procedure, or program or training, and then somebody asks you if it's working, and you're like, I think so. Like, how do you know that is actually changing? Maybe they go down, maybe they go up. There's so many factors at play, like, having that before and after, the metrics on that is huge. And again, having a clinician, having somebody with like a research background or whatever, is so helpful in this, because we're always running, as security directors, we're always running from one fire to the next, and there's not a whole lot of time to pause and reflect. And you're not sitting in your office meditating over the issues. You're like, somebody's banging on your door about something. I can tell you from working in both community hospitals and large academic medical center, there's always something on fire. There's always somebody looking for your attention, and there's not always a lot of time to sit there and really deep think on the issues, or to dig into each individual incident. And even if you could, you're not going to be able to understand the clinical causes, right? We're not medically trained, so having a clinician, they can look at what medical issues were going on at the time that this happened. What are the commonalities between the incidents in terms of the diagnosis, or in terms of what variety of factors were in play, what medication were they taking, things like that, and looking for trends and using that to educate people, using that to prevent violence. That's the stuff that we as security directors can't do, and that you need somebody to focus on. And your safety officer can't do that either. They're not just worrying about violence; they're worrying about everything that can cause safety issues. I go back to the laser nurse. I remember a laser safety nurse. Laser nurse sounds like very futuristic, by the way. But laser safety nurse, I remember at my last job at the Brigham, and I was like, wow, there's one person to focus on laser safety. I remember looking it up like, I guess it's really bad, because you can hurt your eyesight with it. You can burn the patient. There's all kinds of horrible things that can happen with lasers. Makes me never want to have any interaction with a laser at a hospital. But there was one person, not full-time focused on it, but they were specially trained and focused on that for the operating rooms, which is best practice now. So but the instances of laser issues in hospitals, it's like 400 a year, right? And you look at workplace violence, I mean, hundreds of thousands of instances a year. If you look at the official statistics, it's always something like really low, like 10,000 or something like that. That's because we don't really do a great job collecting that information. But the point I'm trying to make here is that, if somebody was to say this is a best practice, if Joint Commission said, hey, you want to comply with our latest standards, here's the best way to do that. If they said it was this, or they said it was something similar to this, people would jump on it, at least if you're accredited by Joint Commission. But that's not happening right now. So,
I think I have a couple of competing thoughts as you're talking, and I'll first, I think you're absolutely right, and it's unfortunate, but you really want to drive change in the healthcare industry, you have to get an accrediting agency to start pushing that change.
Yes.
And so I agree with you. I think the Joint Commission standards will be something that that definitely helps drive some thought process and some change. My struggle with that is, and this is a discussion for another time, but I'm going to make my point and move back on. But accrediting agencies, Joint Commission, DNV, others, they do a terrible job of evaluating effective security management and effective security practice within a healthcare environment. That really is a non-existent piece of the accreditation process. And so if you want to drive or give weight or credence to security as a value add to the organization, we really need our accrediting agencies to take the evaluation of those functionalities a little more seriously. But that's a soapbox for another time. I'll come back to that some other time. The other thing is, I'm listening to you talk, so I'll share, this is one of my concerns when I first read your article, and I think you addressed it earlier on. But one of the challenges I have as I consider this, I think having a specialist dedicated to violence prevention, and we've seen this be beneficial if you look at, the Cal OSHA standards around workplace violence, pushed a lot of hospitals in California to get a workplace violence manager or something to that effect, and so we've seen the benefit of that. My concern is I don't ever want to see abdication of responsibility by security leaders. I feel like part of our issue with workplace violence to date is that our security professionals have either been relegated by their organizations to a back burner status when it comes to assisting with this, with the prevention of violence, or they have abdicated that responsibility to some degree. And the truth is, if you really want to address violence, it does, to your point, have to be collaborative, both the clinical and the public safety side or the security side working hand in hand to mitigate effectively. And I think, where would you see, if you had a position like this, even if, I like the idea of it being a clinician, somebody who understands the clinical side, the clinical care piece for that patient, but would you put this person, under the chief nursing officer, under the security officer, under the, where would you plug somebody like this into the organization? And how do we keep a position like this from becoming an excuse to abdicate responsibility for workplace violence?
I think those are great points, Mike. And I, as you were saying, where should this person report before you said CNO, I was thinking the same thing, chief nursing officer. I think they need a direct line to the C-suite, because if they don't, then you don't get that direct support, right? You need somebody who is a decision maker, who can hear the information direct, who can, make a call on moving forward with, priorities, things like that. So I think a CNO is an appropriate position for that, especially if it's a clinical role. Like, you don't want to, generally you don't want a clinical role reporting through like a chief operating officer or something like that, right? So I think it makes sense for them to report to a CNO. But I think that I would hope that a security director would not abdicate their responsibilities, but I can see, where you're going with this, Mike, in terms of, hey, I'm already overloaded. This is great. We have somebody that's focusing on this now. Now I can focus on the things that I think are my priorities. Up until recently, I can tell you, and I won't say that where this was, but I know of a security director who was focusing on in a very large hospital, focusing on thefts. That was their biggest thing. Like, our biggest problem is thefts. It's like, no, your biggest problem is violence, right? Thefts are a great thing to focus on, because you can say, we put locks on these doors and our thefts went down and blah, blah, blah. And workplace violence is like this big, amorphous, constantly changing, moving target, right? So theft is a great thing to focus on, because you can show, you can put locks on things and cameras and solve crimes, but workplace violence is like this big, messy,
much harder to wrap your arm.
Describe it. It's a big, it's like you put your finger in the dam and then like 5 other holes pop up and you're like, oh yeah, we're gonna fix this.
Yeah.
But yeah, I could see why a security director or manager might say, great, I'm done. Let me know if you need anything. We'll just respond to the calls for service and, do the restraints and keep doing our de-escalation stuff, but other than that, we're done. So yeah, and on the other side, you also don't want the person who gets selected for this role to pull that away from the security director and say, no, this is mine, right? So it has to be collaborative. And, and I can tell you from my time at the Brigham, we had put together a really great workplace violence committee, with representation from the C-suite, and that actually had to report up through the board on at least an annual basis. So, that's just an example of a really good collaborative workplace violence effort, right? You get all the right people at the table. There was I was one of the co-chairs along with a clinical person. So there was like that dual ownership. So, but again, not somebody who's 100% focused on workplace violence. And, one of the points I made in the article is, great, you have a workplace violence committee and you meet every month and you talk about all the, good things you're doing and all the terrible things that happened. And what you're going to do next. And then what happens? Like everybody leaves the meeting and they're like, oh, we're done until the next meeting. We don't have to talk about violence or think about violence. I mean, honestly, you're working on things, you're moving things forward in between. But a lot of the people that go to those meetings or part of those meetings, they have a million other responsibilities. And violence, they think about it right before the meeting. And then when it's over, they get back to what they have to do. So, and that's no knock on them. Every position in healthcare that's in leadership has 10 different responsibilities and sometimes even more. But they can't focus on that, right? So who is maintaining the violence program in between those meetings? Who's pushing those initiatives? Who's keeping people, moving forward instead of reacting to the last thing that happened? And all you need is one really bad incident to happen, right? And everybody just starts focusing on how do we prevent that exact thing from happening again, right? There was just a hospital in Massachusetts where somebody got stabbed, a healthcare worker got stabbed in the back multiple times, randomly by just some random person outside. Now we might find out that there's some kind of connection here later, but it seems it's like a random stabbing outside. So I can tell you that hospital is going to be all about, how do we keep our staff safe outside the hospital now, right? And to a point, you have to address the last thing that happened, right? Your staff are going to be scared. You can't say, well, that never happens here. It's not going to happen again. So you're good. Just go outside. You'll be safe. You have to show them that you're doing something, that you're taking it seriously. And there is a little bit of security theater to that when you do that. But, if you're managing not only the actual violence, but the fear of violence, right? So, I don't know where I'm going with my thoughts at this point, but but what I'm trying to get at is I agree with you, Mike, in terms of what you're saying about worrying about security directors standing back. And I think if you create a position like this, you have to find somebody who's into collaboration and who is dedicated to collaboration, or else it's not going to work. It's the same thing as putting it all on the security director.
Well, and I think your point about having somebody that's continually focused on it in between those meetings is a solid point, because it is that does seem to be kind of the status quo sometimes, is we have a meeting and we talk about it and then nobody does anything until the next meeting, and basically the next meeting just turns into what did we agree to do last time? I forgot. Right. But that is a good point. And I also think, this is why, we call this the Proactive Security Podcast for a reason. I like the idea of proactivity, and you're absolutely right. We get this, when an event, especially a critical event happens, we get this kind of tunnel vision on this one set of circumstances, and we expend an inordinate amount of resources on preventing this one set of circumstances and do absolutely nothing to invest in the broader issue.
Right.
And I think that's an excellent point.
Yeah, thanks. Yeah, it's just, it's kind of like, we just had the anniversary of 9/11 recently. And I remember when shortly after 9/11, we had the guy that tried to blow up his underpants, right? And then it's like, well, we don't have to worry about just hijackers. Now we have to worry about people blowing up their underpants. And before you know it, we're getting, you have to put your hands above your head and you have to go through that x-ray thing and take your shoes off because somebody also tried to blow the damn shoes up. So, but it's like the same thing with hospitals. It's like, whatever the last thing was, now we got to worry about that. Somebody attacked us with an IV pole, take all the IV poles off the beds in the emergency department, right? That was one person, that was one thing. Like we're not addressing the root causes, right? We're not addressing the frustrations where, there's just so many aspects to this. And it's just such a dynamic problem that it can't be dealt with by one person, one department. It needs to be coordinated and collaborated, but you need somebody to be chasing people down constantly and saying, hey, where are we with this? How is this going? Like, move initiatives forward. You could even have a project manager to do something like this. I've seen some really great project managers move workplace violence initiatives forward. People who had no experience in healthcare, but awesome experience in project management. What they're doing? They're setting timelines, they're writing things down, they're keeping notes, and they're holding people accountable. Hey, the next meeting is X. Where are you at with this draft policy? Right?
Yeah.
And this person has no horse in the race, right? They're just the person keeping people on their toes. So imagine you take that project manager type person and you add the clinical on top of it, right? I think we're looking for a unicorn at this point, but imagine, and they can help you with restraints. But if, it just goes to show, like, if you have somebody, the point I'm trying to make is if you have somebody dedicated to it, right? This was
right.
A project manager, and this was at the Brigham. This was a person who really helped us form that workplace violence committee, but they kept everybody on their toes, and they would, reach out to you before the meeting, not the day before, 2 weeks before.
That's how I do it. I like to reach out, an hour or two before the meeting.
Yeah. Did you write that policy? I'm doing it right now.
Yep.
What are the minutes? I'll have them by the time we get there, So it's, having somebody that can really chase people down and help focus energy in the right direction is huge. So, like I said, maybe you find that a project manager is better than a clinical person or whatever it is, but you need, the idea here is to have somebody outside of security, preferably with clinical experience, somebody who can keep this program moving all the time. And I think that the research piece is huge too. So maybe that person doesn't have a research background, but you have, somebody who's got a research background who can help analyze the data, right? Like, think about what's in your security reporting system. It's, here's the incident that happened. You have no information in there about the clinical situation, right?
Yeah.
You're not looking at that. And even if there was, you wouldn't know, whether that was a proximate cause or whatever. So you need somebody who has that background to really dig into that stuff. And, one of the things they did at Brigham is they started doing, I think it's delirium assessments, something like every hour on every patient, which is just like a 2-step process, like real easy. But they started doing that because they saw that a lot of the causes of violence had relation to delirium. So if you can identify that early on in a patient, then you can take measures to help prevent that from becoming a larger issue. And I think that's in that article as well, that research article. So people are going to read the article and be like, Dave, it doesn't say any of this. I don't know where you're getting this from. It's a really good article, but it's worth a read. And it's not written to the point where you're like, what happened here? I always go to the conclusion. I'm like, did this work or not? Right. But it's actually a good read to go through that article and just see how they approached it. But yeah, I think that I just hope that people read the article and listen to this podcast, of course. And even if it gives you a spark to think about things differently, that's my only hope. I mean, my goal with when I share thoughts is to get people thinking in a different way, because one of my frustrations is just seeing people. I like to innovate. I like to do things differently. And being outside of healthcare now, I get to come up with all kinds of great ideas, but I don't have to figure out how to do them. So, but I like to hear the feedback because, if somebody said, hey, Dave, you're crazy for coming up with this idea. This doesn't make any sense. And Mike, when you said, I have some issues with how you're saying to implement this, like, I like that. I like that interaction, because I want a reality check. I actually want somebody to do this and say, like, hey, this worked, or this didn't work, or, it would be interesting to see. And I was hoping to hear from somebody that had, like, maybe not this position, but something like this. So maybe somebody will listen to the podcast and say, hey, we did something like this, and here's how it worked. I'm sure somebody else is trying to do it.
That's the challenge to our audience right there. If anybody out there is listening and they've executed on something like this, reach out to us, let us know. We'd love to follow up this episode with a discussion about what it actually looks like in a hospital setting.
But if it didn't work, it wasn't my fault. Just saying.
Fair enough. Fair enough. Well, this has been a great discussion, Dave.
Yeah. Thanks guys for having me. I appreciate the opportunity to talk to you. And I'm a big fan of your show. So appreciate you inviting me on.
Our pleasure.
Well, yeah. Thank you so much for coming on, and thank you for even though you've transitioned out of a healthcare facility, we thank you for still being passionate about it and still coming up with solutions, because it's all helpful stuff, and it's great to have these conversations.
You're welcome. And if you see my article and you want a reality check me, please do, because I'm outside of those four walls now, and I might be coming up with some crazy stuff. So
don't worry. It's linked in the description, so some folks may take you up on that.
All right, guys. Thank you so much.
Thanks so much, Dave.
Bye.
Thank you, everyone, and until next time, stay proactive.